We have always had the response on the heavy apparatus for EMS calls. What's happened in the last, since 2011, is our approach is to send apparatus, a heavy apparatus out on initial calls, and we probably roll a little bit more on initial calls. One of the reasons for that is everyone on the truck is trained to the emergency medical technician basic level, meaning that they can perform the same skills that the 58, I think it is, BLS units that we have can perform. Instead of getting 2 EMTs, you get 4. Mm-hmm. The weakest link in our triage and treatment of emergency medical calls is the caller. Calling, trying to explain exactly what's going on. Sometimes they can be very detailed and sometimes not. Usually if they're calling, most people it's the worst day of their lives, and we're asking them to tell us where they are. We're asking them to tell us what's going on, and they feel like that's a waste of time. We just need you to get here. What we found in our emergency medical system is we probably only transport a little less than 50% of the people that call. So when we do get a call and there's very limited information, we'll send those 4 closest EMTs or the 2 closest EMTs if an ambulance is close to go to do a little bit better assessment than we received on the phone. And from there, they may call for an ambulance. They may be able to mitigate the situation. The caller may refuse service, or sometimes we have a program called Ethan where we get them in touch with a doctor, sort of a teleconference with video or video conference. The doctor will evaluate, will give them the vital signs, and a decision may be made. Yes, they need to go to the hospital, they need to make an appointment with their doctor, or they can follow up with their doctor. So in that regard, emergency medical services changed. Now when it comes to paramedicine, they've made some more advances from when I was in the station. I mean, we would intubate and give certain drugs, but now they do intubate, they do give certain drugs, and maybe even a little bit more sophisticated drugs, especially when it comes to stroke and treating other seizures and things like that. So they've made more advances as we've learned more, and doctors have been more comfortable allowing people at the paramedic level to apply certain interventions into whatever medical emergency may be going on. There have been a lot of advances with that. In our city, because we have a medical center that's in close proximity to a lot of places, we may not do as much as others, but we have access to really good medical facilities in a fairly short time frame. Mm-hmm. One other big change we've seen is we've partnered with the University of Texas for what we call a stroke medic unit. And this ambulance basically is a rolling CAT scan. Yeah. So the pilot program involved if there's a stroke within a 3-mile radius of the medical center, we would contact this unit and they could meet us on the scene to perform a CAT scan. And the reason they do that is there are certain drugs that if you identify that a stroke is of a certain type of clot opposed to a bleed, this drug is amazing at reversing the effects of a stroke and shortening the rehabilitation time exponentially. So that's another advance that I've seen with EMS, just partnering with the private sector or even public medical institutions when they're trying to test out different things. And I've seen a lot of that. We've tested monitors, we've tested automatic defibrillators, we've tested different types of maybe backboards or stretchers, and I've seen a lot of that happen with emergency medicine. There is an interest in getting better, and it's just not a kind of throw everything out there. There's a process and a testing, and we're glad to be a part of that.